He'll tell you a bit about himself, maybe. Mark is the Programs Integration Manager in the HSE, and he's going to talk about a better health service.
Thank you. Thanks very much, Steve, and thank you both to the Faculty of Nursing and Midwifery and to the Leadership Centre for inviting me here today. I very much appreciate it. Having had some sort of introduction from Mary earlier and Juanita alluding to me in our last presentation, I feel it is a really high bar that's been set in relation to what I'm going to talk to you about here today. And I'm hoping to cover 4 items. One really is in relation to, we talk about the programme for health service improvement and what that is, and I want to give a little bit of context to that because although I probably know about a third of the people in the room here and I feel like I'm at a reunion with some of the faces that I see here, I'm very conscious of the fact that we have some international visitors and you're very welcome here today. So I'm just going to talk about the programme that we have for health service improvement. I want to briefly talk about some of the things that we are doing and the health service is doing and how the programme for health service improvement is improving that. I want to briefly talk about some of the literature but also some of our own anecdotal evidence of what supports high performing programmes, the characteristics and challenges, and of course that will lead me straight into the theme of today, which is leadership and values. Most people here, if you thought Juanita spoke fast, I have about 22 slides in 20 minutes, so I'm going to try and be understood and just like Juanita and try and get through my slides. So most people that I meet ask me what is the programme for health service improvement. I wake up every day and I ask myself the same question in relation to what it is that we do, but in essence it's an overarching body or an overarching umbrella that pulls together and coordinates the efforts of all of the work in the health service and the improvement work that they do. A lot of the improvement work falls out of strategies and frameworks and policies that are imposed or mandated on the health services by HICWA, the Department of Health, and believe it or not, the health services ourselves. So when Juanita put up, I think there was 4 policy documents that are guiding Schwartz rounds. You've got to understand that the health service itself is guided by many policy documents and focus areas. So Dilbert, I pulled this up last night. So you can imagine how difficult it is for somebody to say you've got only got 25 focus areas to work on in the next year. So we did a little exercise in the programme for health service improvement, and this is meant to be a complex document because it is a complex document. And if you can see, and your eyesight is better than mine, there's actually over 44 focal points for the health service to deliver over the next couple of years. So the health service, and I love the way Juanita referred to organisation. We're multiple organisations. We're a system. We're a health system. The health system is guided by multiple policy directions. And if you look at number 11, 11A, B, C, D, right down to I feel so sorry for anybody in the acute hospital services because they're guided by 11 policy documents that are their key focal points and then the multiple focal points within those strategy documents. So this is just to highlight the context that the health system and the health services is really complex and really complicated. So what we've done in the programme for health service improvement is we've tried to coordinate and facilitate people into bite-sized chunks, and we've created portfolios of work within the health service that look and separate service design, service delivery and enabling programmes, and that essentially means that there are 12 large major programmes in the health service that fit within those 3 governance arrangements: service design, service delivery and enabling. But there are over 500 detailed programmes of work that are looking at areas of improvement or quality improvement within the health service, and our job in the programme for health service improvement is try to make sure that they integrate, that there's no overlap, and there's nothing as bad as as finding out that you've just delivered something and someone in another part of the country has just delivered the same. So we try and network people to make sure that those things don't happen. And in essence, that's what it looks like. Now, in addition to the tension that the health services are under, there are also the additional challenges of not just policy tension and policy direction, but the additional challenges of which most people here today know about chronic disease, pressures, obesity, dementia, our mental health, staffing and our staff well-being, and additional community tensions of trying to get people into a community-based model. So what is the health service doing? And I've listed 8 things here, just to prove that these aren't just sound bites, my next slide is just going to say what it is we're doing about these. So the health service and the programme for health service improvement are listening, we are prioritising, we are working to ensure that everyone has access, we are focusing on safety and quality, we are improving process, and we are reorganising, and we are investing, and we are supporting. And those are easy sound bites to make, but beneath them are multiple programs. So I'm just going to focus on, these top 2 here. If I just spend 2 minutes looking at how are we doing that, and then I'll move on into the presentation. So in terms of listening to people's experiences, the health services is joining up health and social care under the community healthcare organisations to deliver and improve community health services for health and social care. Now the programme for health service improvement supports that by providing resources that enable the development of these, and they help implementation plans and put governance and structures into a delivery framework for community healthcare organisations. The health service are designing the future for integrated care, for example, with older people, and CSPD, the Clinical Strategy and Programmes Division, do that. The Programme for Health Services for the PHSI provide resources to help plan that, and we support the secondary care services for older person in consultation with key stakeholders, and we put resources, people and structure into that work. The health services themselves are improving the patient experience, for example, and I've just pulled this one out with hemochromatosis, and the Programme for Health Service Improvement have put resources in place that have helped deliver and design those models of care. And again, if we look at trying to get patients to have home antibiotics, which would be is one of the design features of the health service and our community model of care, well, the Programme for Health Services help with the provider tender document and have helped set up community intervention teams to provide that outpatient parental therapy. The second area, I just want to pull out some of the things that we are doing and some of the things that we've achieved in terms of prioritising and resourcing and encouraging prevention. We've helped health and wellbeing look at their future operating model and how they're in the new health service going forward, which is very much focused on hospital groups and CHOs, how they're going to operate in the future. In terms of improving rapid access clinics for NCCP, we've helped with the review. The current services, we've looked at identifying gaps in performance, and the Programme for Health Service Improvement have also helped develop the implementation plan for those. In terms of the negotiating the new GP contract, which supports primary care, the Programme for Health Services has helped with the negotiations and talks in relation to that. We've done a massive public consultation survey with primary care, and again, we've helped include members of public representative bodies have their say and consensual say in relation to the new GP contract. So I just wanted to take this opportunity to sell the wares of what, because people are very, it's very easy to say that the health service is static and nothing is happening. But there are lots and lots of little pieces of work, improvement work, and our job in the programme is to try and make sure we pull all that together. We're just about to launch in the next 2 weeks a microsite which is going to on the health services website, which just looks at this good news stuff, because so often we tend to go to the bad news stuff. So we're going to use the powers of technology that no matter what you search for the health services executive, you'll only get the good news. So whether you're at home or whether you're a journalist, when you put in HSE, you will only be brought to the microsite that has our Building a Better Health Service good news stories from patients and service users and sites. In terms of where we are and what we've done, I think it's fair to say that the Programme for Health Service, when you think about the complexity of the context, we really only are at base camp at the moment. So what we've done is put some really strong programme governance around that, those bite-sized chunks that I talked about, which are service delivery, service design and enabling functions. We've helped all of those programs, those 500 detailed programs, have a project plan, a Gantt chart, a start, a beginning, and some program project governance around it, and local program support. Where we want to be in the middle of the summer is that we actually have clear sight about an operating model of how the service delivery, the community healthcare organisations and the hospital groups will function and operate, but more importantly, as we shrink corporate HSE to be a commissioning type unit, how are they going to function? And we're in the middle of doing lots of workshops there. So in terms of camps and reaching the summit, we're hoped by the summer to be only coming up to Camp 1 and know that we've got a lot of work ahead of us. I'm very conscious that today's theme is about leadership and values, and we've spoken a lot in the previous speakers have spoken a lot about values and leadership. So I'm going to dedicate the rest of my 5 or 10 minutes to looking at change, how that is supported by leadership, and as Cotter said, without leadership, actually change is it'll starve. It'll be starved of oxygen. It's almost impossible. So the two are interlinked. And if you're a leader or a frontline manager or in a leadership position, and most people can choose to be in a leadership position or not, change is part of your brief. Yes, there's business as usual, but there's also change and improvement. So what we've done is, when we've looked at the programs of improvement across the health service, we've identified 4 things which are actually very similar to the findings of the King's Fund, and obviously the King's Fund do good work, because Juanita mentioned the King's Fund in her presentation previously. But there are 4 characteristics or elements that really stand out from high performance programs, and they are clear vision and leadership, organisational capacity and capability, because that includes skills, program delivery and governance. And I can't overemphasize the governance piece, because governance actually mandates you to deliver what it is that you're supposed to deliver, and sponsors what it is you're supposed to deliver. And also the whole area of culture, teamwork, continuous improvement, and we need to mention engagement, how important that is. If those 4 ingredients are there, there's a fairly high likeliness that your program or your project, whether it's small, local, or high strategic, will have some level of success. And we have found that with the programs that have made real inroads in improving the health service here in Ireland. Now, in relation to clear vision and leadership, I specifically, Mari brought this up in her presentation here, a lot of organisations really focus in on vision, mission and value statements, and it has become very trendy now for people to pull value statements out of the air, and in relation to that, we work in the health service. Our value statements they're written on the bottom right hand: trust, compassion, learning, and I've forgotten one, care, of course, the most important: care, compassion, trust and learning. And those value statements, like value statements in any organisations, generally are pulled together by the management team or the CEO of an organisation. So I want to talk to you now about the Values in Action initiative that the Programme for Health Service Improvement are supporting and sponsoring. And I'm going to dedicate the rest of this talk to talking about that, because I think it's probably one of the most exciting things that I've been involved in my very few years in healthcare. Because what we realised is that the most important thing is missing in that scenario and in that continuum, is that we all forget. And I would say it if the chief nurse was here. So it's great that the chief nurse has mentioned values, but nobody goes to the bother of articulating what does that mean. Because values are nothing unless we can articulate what those behaviours are and those actions look like. So it's very easy to make value statements and very easy to pull value statements like care, compassion, trust and learning. But what does that mean in practice? So we have started a Values in Action project, which is unique, I think, internationally. What the Values in Action project is that we understand that every day everybody in the health service tries to live the care, compassion, trust and learning values, and sometimes it's visible and sometimes it's not. But the project itself is working to spread the culture in the health services that actually it should be visible all the time. So the aim is to make our values a way of life for us, so that they're not just words and not just value statements, but they actually are something that we live. And if you look for a definition of culture, culture is behaviours and actions. So if we're trying to create a culture, and Juanita talked about culture, it's about our behaviours and actions. It doesn't matter about the value statements, it's actually how we behave. So the VIA project, the Values in Action project, it's about living our values for our staff. It's about actively developing that culture where our values are a way of life. It's the way that things are done on every ward, in every department, in every community setting, in people's homes, and in every outpatient interaction. And we started this project in the Midwest last year. We've started there, but I'm going to talk about the journey there. I have 5 minutes, so I think I'm just about make it. So in order to shape our values, we looked to try and get consensus, again using Mari's consensual management, consensus from a large group of people in the Midwest to try and understand and translate what those values or words mean in terms of behaviours. And it also, the project uses peer-to-peer approach to shape our culture and try and get some sort of viral shift and momentum with that, with viral change. Viral change, I realised this morning, I was looking at this, should be the other way around, but it uses the power of a small set of well-defined, non-negotiable behaviours that are spread by small groups of highly connected individuals within the organisation. So it's a bit like Lewin's model of change. You're looking for small groups of people to tip that balance so that it becomes the norm. And Leandro Herrero, who I'm going to talk about very briefly, has said that we can map and talk about values and change and all of that, but unless we don't change people's behaviours, all we have is the illusion of change. And I think the reason why one of the main reasons why the Programme for Health Services is investing so much heavily in this is that we're actually trying to influence people's behaviours and not just have the illusion of change, which is one of the criticisms of all the change programmes in the Irish Health Service and every health service internationally. So very briefly, Leandro came to Ireland last year at our comms conference, and he talked about viral change and the power of it, and he has a thing called the Challenford project in the UK. We took that with an oversight group, we got expressions of interest, we chose the Midwest, we asked for email nominations, and we got over 50 people from cleaners, domestic staff, to the managers of the healthcare organisations in the Midwest to come together and get consensus about what it is our values were in terms of behaviours. And we came up with 3 dimensions. Our values are things that reflect on us and individuals, that guide how we interact with our colleagues and how we behave in a team, but also they demonstrate how we treat our patients. And we identified 9 behaviours within those 3 dimensions. So how we manage ourselves, how we manage ourselves with our colleagues, and how we manage ourselves in front of our clients or patients. And those behaviours started to come out like this. So dimension 1, as an individual, do I put myself in other shoes? Am I being fair to my colleagues? Can I see things from other people's perspectives? Am I aware that actions can impact on how patients feel? Am I aware of how my stress and how I work and I deal with my stress impacts on others and impacts on patients? And I know from my own experience as a nurse that sometimes you'd ask a client, you'd come and a patient may have missed the toilet or didn't get the call for a commode, and you ask them, why didn't you call in time? And they'll say, oh, it was because that other nurse was on, or that other healthcare assistant was on, and she looks very stressed, she looks like she's angry, and how we are ourselves actually does have an impact on patients. I could talk for a long time about that, but I'm under a bit of time pressure. So how we act with colleagues, we've identified 3 behaviours within that dimension. So acknowledge the work of our colleagues, acknowledge when people are under pressure, acknowledge and say thanks, have human interactions and human-to-human contact with our colleagues, treat people with respect, regardless of their hierarchy or role within the organisation. Ask our colleagues if we can help them. We often see people stressed and all we do is put our head down and walk straight ahead and try and get our work done. So this is about creating a behaviour, an acceptable behaviour where it's okay to say I need help, but it's more importantly to offer help. And the final one, it's about challenging toxic behaviour and not accepting that we can never change or improve, but try and not be a bystander and try and get in and challenge when people are not behaving the way that they should in front of patients, colleagues and our family members and staff. And finally, with patients, really important stuff that we all know but we've never articulated and put a name to. But do I use my own name? How I introduce myself? How I deal with people? Do I have eye contact? Do I have time? Do I give them the communication and keep patients informed? And the whole reason why we're all in healthcare, do I go that extra mile and do that extra kind thing? They are the 9 behaviours. They're absolutely unique, because I think in the first time when I've searched the literature, lots of people mention values. Nobody has articulated what those behaviours are. So we have a really exciting piece of work starting here in Ireland. Our problem with all improvement initiatives is about sustaining and maintaining. So we have a couple of things that we've done. We've started peer networks. We use social media. In the Midwest, they have their own little Twitter account. They use another social media piece to keep in touch with each other. They share stories of success. They keep in contact with each other in a guided site. They use group chats, peer support. We're utilising the viral change. We've continued our relationship with Leandro Herrero from the Challenford project, who kicked off this project for us. We use social media to try and celebrate all successes with the project. It is now, the project has gone into rollout phase. It's been adopted by the Director General of the Health Service and is named as his priority for 2017. We are planning to have a national rollout, and if people in the health services here have seen that there was an ad went out 2 weeks ago, nearly 3 weeks ago, and we've had over 300 people apply to be part of the team to roll this out nationally. That's unprecedented in the current climate in the health services. Over 300 people want to be part of this. It's such a good news, good thing to do, and we're planning to have a very robust evaluation. I'm around for the panel discussion, so I'm happy to take any questions then. Thank you very much.